I've been taking care of nuss patients for pretty much that amount of time with Dr. Lasasso and working with him. And one thing I will say is that you guys will love working with him. He's amazing. He's so easygoing, the nicest, most approachable man, has an excellent bedside manner, is really kind to all the nurses, totally will be very appreciative to you guys. He loves talking about this surgery. And so if you have questions or anything like that, you can definitely stop him and ask him or page him and say, can you call me back when you get a chance or something like that. He's very, very approachable. And then his office is in North County in Encinitas. He lives in Encinitas, and his office is in that area where he sees his patients post-operatively. And I just really enjoy taking care of these patients. So I think that that's why Renata, the other nurse that's teaching the class, is going to be helping with this. We both have just really, I don't know, kind of came together and we're like, we should do education on nuss post-op care. And we helped Dr. Lasasso with the order set of nursing care post-operatively. And all of our paperwork is now in the Epic computer system for our orders and everything. I don't know what you guys have over there, but this is basically a paper form of what the post-op orders are. So if you want to just look at it to get an idea of what those might be like, they're inside here. It's kind of old since everything is on the computer now, but at least it gives you an idea of what you might be looking at when they come back to you post-op. And this is a resource finder that we created for the unit. So I know Diane was talking about maybe doing one for them as well. And so we have a nice group. We have some experienced nurses, I assume, and then these nurses here are all new grad nurses. So they're going through our new grad program, and I wanted to congratulate you guys because I know how hard the job market is right now for nursing, so congratulations and welcome. I'm glad you're all here. And Josie, you were in Bernardi before, right?
I was in Bernardi for 5 years.
Oh, that's so great that you flew over here too. So we'll just wait until Renata's making one more copy, so everyone has one so you can write notes or anything. And if you have any questions at all, just feel free to stop and ask. This can be very informal and casual and just a learning experience. And I gave Diane some cards to our unit for the sharp nurses. If you guys have questions any time of the day, we're always here, an experienced nurse that takes care of these patients. You can call in the middle of the night and say, hey, I'm having trouble with this part or pain control, or I'm concerned about this. Just call us and ask for someone and we'll be able to resource you, try to help you as much as possible. And for discharge medications, our pharmacy is open on Saturdays, our outpatient pharmacy, and they do have the OxyContin and the Percocet and Valium that these patients go home with. Even though we're pediatrics, we fill adult prescriptions as well.
When you guys bring the patient in, do you check with their insurance to see if our pharmacy is gonna work with their insurance? Because the patient that we just took care of, we had an issue discharging him with prescriptions.
Yeah.
So I was just wondering if there's a different process that you guys do to make sure that that doesn't happen.
So our pharmacy takes all insurances. So it shouldn't be a problem, and they're also very familiar with filling the prescriptions for this type of surgery as far as any confusion or anything like that. And then the patient that you guys just had, I understand, was a double bar nuss procedure. Usually it's just a single bar nuss procedure. It doesn't mean you're not going to get double bars, because you definitely get double bar patients. But the OxyContin that they typically go home with is 10 milligrams, and that one was 15 milligrams, which made it even more complicated to find in the community, which added to the discharge complication process, which we all know those are really hard to troubleshoot a lot ahead of time because things just sort of come up and you try to deal with them the best you can. But I think that it should go better for you next time, because
also too, we're not used to sending our patients out with prescriptions.
Yeah.
Unless, like, they don't have insurance and then they get, like, X amount of doses given by our pharmacy downstairs, so it's kind of a new process for us.
And you will have different types of insurances now because Dr. Lasasso is very well known for this surgery, and so he gets patients even from the East Coast that come here for this surgery. Almost all of the West Coast patients come to San Diego for the surgery. So you will have a lot of different insurance things. So that might be something that you guys could try to discuss about trying to troubleshoot ahead of time and seeing where they can go. But I'm pretty sure our pharmacy takes all insurances. And then if you could have them filled before they leave, that's really important too. And to review those medications with the families before they leave and make sure that they have them. Because they are going home on a lot. And I understand that the Sharp nurses don't have a pain team, right? You don't have a pain service team?
We do.
Oh, you do?
Yeah,
Okay. Because our pain team reviews the medications with them before they go home and sits down with the families and makes sure that they all understand. And just be aware that you really need another adult there that isn't on narcotics sitting down and going over the medications with you, because the patients are on so many narcotics that there's no way they're going to comprehend everything that's going on. You might think they are, and they might get quite a bit of it, but they're on so many narcotics, there's, you know, they're going to need somebody else who understands, who can take notes and make sure that they have everything they've got. Is Casey coming with that?
Yes.
Okay. We were talking about narcotics.
About what?
Narcotics.
Yeah.
Okay. Should we start since Casey, and then we can get you another copy? Is that okay?
Yeah, that's fine.
Okay. Let me see if I can. So this is, first what we'll do is we'll do the, actually, why don't we go over the definition of what it is first, which is on this page, the pectus excavatum, the sunken chest. So I know you guys can all read through this on your own, but basically the definition is of a sunken chest, and it's a depression in the chest. And it can cause cardiac complications, it can cause respiratory depression, and just fatigue. So there are, and then also, I guess, it used to only be done a long time ago for cosmetic reasons, but then they decided that insurance would cover it, and that it really can cause cardiac complications and respiratory issues, so it's changed. But these patients are very happy after the surgery because when they get to look at their chest, it's not sunken anymore, and they get to see results right away. So providing them with a mirror to be able to look at their chest is a really important step in their recovery. So if you can have a mirror on your unit, it's good for them. So this is information that the families get also, but this explains everything about the pectus excavatum. And then Casey, I'll let you do this one. And then this is a picture of Dr. Lasasso, and that's Dr. Nuss. And so he taught Dr. Lasasso this surgery, and they studied together. And so this is his PowerPoint. Have you guys received this PowerPoint before from him? Have you guys met him?
He came and did a talk, so probably.
Yeah, okay. Yeah, so we'll go through this kind of quickly, and we'll focus on the nursing care afterwards. So these are, okay. So this is, it's more common in boys than girls. It's 4-to-1 ratio. 90% is seen after the first year. We'll go through these kind of quickly and focus on. And then that's, of course, the anatomy of the chest, which you all know. And then this is where the pectus would start to occur in the body, and that's more of the anatomy. And these are reasons why it can all occur. Sometimes you'll see it in Marfan's. It's typically males that are leaner. And then there can be some anomalies of the cartilage like zinc and magnesium and calcium, and it also is familial in some cases. And then there's different theories of the sternal depression, and so that's measured preoperatively. And that's just a picture of the depression. And then it will go into the Howler index, that's how they measure it. And then these are what it can cause. Some murmurs and respiratory restriction and chest pain with exercise. That's usually the biggest thing, is that they get fatigued with exercise. And this is just a little bit of the history of the surgical treatment before. They used to do an open chest pectus, and that was called the Ravage procedure in 1949. So when the nuss procedure came along and they were doing the incisions on the side, it was like a breakthrough in this surgery. And this was the Ravage procedure that they used to do, and it was all, the nuss procedure.
Cut the cartilage.
Yeah, they would like take the
cut
sternum
the
almost
car-
off, and like redo it.
and then reapply the sternum. And then they would have to lift the sternum out also. And then, this is just more about how to modify the Ravage procedure. And there were, when it was looked at as being strictly cosmetic, there were cosmetic implants that were put in, so this was a cosmetic implant. I know it doesn't matter. And then the nuss procedure came along, and Dr. Nuss developed this surgery, and then he taught Dr. Lasasso, and Dr. Lasasso studied underneath him.
Were there someone Dr. Lasasso's teacher?
He actually did.
Yeah, he was teaching. There was another surgeon here. I don't know.
Actually, Dr. Lofika did the two of them as well.
Yeah,
And
and then she
Dr.
doesn't do-
Grabowski, I
Grabowski
think, did
did one,
one. Yeah.
And Dr. Science has done one before too, but they don't do them now.
Previously, Dr. Kennedy too, but he left.
Oh, yeah, Dr. Kennedy did too. So this is the rationale for the nuss surgery. And in children, usually we don't do this surgery until they're at least, I think 12 is probably the youngest I've seen. What do you think,
Mhm.
Ramona?
Yeah.
12. It's such a huge surgery to undergo. The physical pain afterwards, you really have to be at a place that you can tolerate it.
Is this like the same surgery that they do with a patient with small, like small ribs, like, they expand it like surrogate, like as they grow, the kids grow, they kind of like expand the ribs, stuff like that? Is this the same
Not
surgery?
exactly, because this
No.
doesn't change with them as they grow.
Oh, okay.
So usually they do it after they've hit, like, they wouldn't do
Oh,
a
okay.
kid that's gonna all of a sudden then have a huge growth spurt.
Okay, because we have one kid, we have one patient before that still like do that serial like surgery on, I forgot the, but it's like has a small chest, like, and then they have to like expand it like so as the kid grow. I don't know, because I know like some doctors from East Coast has to fly here to do surgery with Dr. Lusasso, I think.
Oh, we'll have to ask him, we can ask him
Yeah.
about it when we see him.
Yeah, or was it doctor, but I remember it's like some doctors from Seattle or.
We can ask him about it.
Yeah.
He likes talking about all those different surgeries.
Yeah.
So these are the different surgical indications of why you would want to have the surgery. And at the bottom it talks about the Howler index. So if they have a Howler index greater than 3.25, then they would qualify for having the surgery. And the Howler index is the measurement of the chest depth of the indentation. And then you can see right there on it. Does everybody see
Sternum
where it
and
is on the
vertebra.
sternum? Does everyone see that? And then this is what they need to have done preoperatively, and so they'll see Dr. Lasasso in his office for all of this. And they make a template of how the bar is gonna look in the office ahead of time too. And then this is how they measure for this bar.
And doesn't he manually shape?
Yeah,
He like will
shape
manually
it.
shape them based
Shape.
on their exact deformity. So it's
So
really
every bar is
specific to
made
them.
specifically to them. And then these are the tools that are used for the insertion. So there's usually 2 incisions on your non-dominant side and 1 incision on your dominant side. But that's not necessarily always the case. You can have 2 incisions on one side and 1 incision. It just depends on what happens when they get into the OR. But that's how they insert it, and then they put the bar in so that it's not, so if the bar is like this in the chest, they insert it like this, and then they flip it after it's inside the chest.
And one thing that we didn't know necessarily when they first started coming back to our floor is that when they flip the bar, it takes a lot of strength to do that, and they sometimes have to like lift them up off the OR table. We had a kid that came back with a neck brace, and we were like, why does the kid have a neck brace? But they put the neck brace in them sometimes to flip the bar. That's how intense it is.
So it flips from the bottom up then?
So they put it in kind of like upside down kind of.
Yeah,
Mhm.
upside
Because it's
down.
bent outwards, and so they put it in so it's bent like a U, and then they have to
And then they
flip
flip
it
it.
up to like
And there's
the
a
mountain.
handle
So it
on
goes up under
one
the
side
bottom
of the
of the
bar.
sternum.
Mhm.
Okay.
So there would be 2 people on either side of the table, and they're working this bar into the chest. So if you can imagine the tissue and the muscle and all of that going and getting the bar into the chest. And then after the bar is in the chest, then there's, 2 people on each side of the table where they flip the bar. So these patients have a lot of pain, besides the fact that they're on the table for a long time and they're being moved. So sometimes they'll say, oh, my hips hurt, or why is my shoulder hurt? Why does my shoulder hurt? I had surgery on my chest. Well, you were on the table for a long time and you were being moved around quite a bit, so that's why. And so that, again, that just shows you more. And that's the handle. You can see the handle there off to the side above the instrument. And where they insert it above the heart. And then you can see how there's several people with their hands in there getting ready to.
And as soon as they flip that, the whole chest then pops out. Yeah.
I know, it just makes you go. So there's the flipping. So you can have several incisions along the sides of the chest, and then you might also notice, I'm sure he'll do the same thing at Sharp Hospital, there'll be staple incisions sometimes along the upper chest and the lower chest, of where they staple the sterile sheet to the chest. So you might have little tiny scratches that people say, what is this? And you can let them know that that's where they stapled the sterile sheet. And then they'll have incisions with gauze and tegaderm usually over them, underneath the armpits. And then occasionally, you may have had this with the double bar patient, you'll have an ACE wrap for pressure and swelling that'll go all the way around the chest and be very, very tight, and they'll want to take it off, and they'll be asking about when they can get it off, but that's for pressure and swelling when they've had to do a lot of manipulation. Usually a couple of days, like 48 hours. And then he takes that ACE wrap off. So you don't want to loosen the ACE wrap or touch it post-operatively at all until he takes it off.
But it
And
is
if there's a concern though, or you need to look at bleeding or anything, call him and let him know, and take it off and assess what you need to assess.
So you won't be able to visually assess the surgical site for 48 hours?
If you're worried about a lot of bleeding or something going on, then you could take it off and remove it and call him and ask him about it. So that's just more the surgery, and then how they secure it with sutures. And then post-op management, so that's what we'll go over, is we'll really focus on the nursing care post-op. So they need to be on a cardiac monitor, they need to be on a pulse ox,